Diabetes mellitus is a disease which is ubiquitous. Almost everybody has a family member who is suffering from diabetes mellitus and its complications. Diabetes is a silent disease, it's a non-communicable disease, but the most dangerous disease. Diabetes itself affects every organ of the body. It causes paralysis in the brain, it causes myocardial infarction, heart attacks, it causes vasculopathy, neuropathy, and amputations of the feet. And of course, diabetes affects kidney. Previously, it was called as diabetic nephropathy, but now it has been called as diabetic kidney disease. This simplifies the term and makes it lucid to understand for the general public and the patient and relatives. If you enter any dialysis department, then around 60% of the patients on dialysis, that is end-stage kidney disease, would be having diabetes mellitus as the primary cause, while hypertension would be around 30%, painkiller abuse, medicine abuse, and stone would be around 10%, and 10% would be unknown, in which there are small shrunken kidneys, and whatever tests you do, you may never ever come to find the cause for end-stage kidney diseases. In India, there is something called as the metabolic syndrome. That is a triad of diabetes mellitus, hypertension, dyslipidemia associated with obesity, and all these factors together cause more morbidity and even mortality in Indian patients. So, diabetic kidney disease as a part of the metabolic syndrome is a requirement for research by nephrologists in India. Diabetes mellitus leads to very high sugar. Now, that very high sugar finally reaches the filters of the kidney, the glomeruli, and the glomerular corpuscle is the place where the primary effects of high sugar occur. Now, the glomerular corpuscle consists of various cells. There is the afferent arteriole, there is the efferent arteriole, there are the glomerular capilli in between, and those are having the endothelial cells inside, and outside there are the podocytes, which are covering the glomerular tuft. Now, the area between the endothelial cells and the podocytes forms a fusion that is called as the glomerular basement membrane. Now, the glomerular basement membrane opens into the filtration slit, which is in between the interdigitated pedicels of the podocytes, which means that the adjoining ones are from different cells. Now, whenever the glomerular basement membrane is seen, it is around 300 nanometers in thickness, while the perforations are approximately 80 nanometers in size. There is also a charge selectivity and a size selectivity of the glomerular basement membrane. That is why the negatively charged albumin is repelled back into the blood circulation. The solutes and the solvents, they all come out as the ultrafiltrate in between the filtration slit. Diabetes mellitus high sugars also affect the mesangial cells. The mesangial cells are the ones which are the framework of the glomerular tuft, and they are there for clearing out the various proteins which are deposited there. In diabetes mellitus, there would be a decrease in the clearance of the proteins from the space, so there will be mesangial expansion next to the mesangial cells, and also there would be apoptosis, that is death of the mesangial cells. So the structure of the glomerular gets damaged. Now this is going to be a diseased glomerulus. Also, there will be a problem with the tubuloglomerular feedback, which is for the proper functioning of the glomerulus per se, and the macula densa area is also affected, which leads to a problem in the filtration of the glomerulus, and a homeostasis of the body gets problematic. Whenever there is an overload of glucose into the glomerular spaces due to the damage to the filtration slits, the podocytes, and the glomerular basement membrane, the perforations which are present there. So, albumin and other molecules would not be repelled by the charge selectivity and the size selectivity, and they would leak into the Bowman space, urinary space. Then they reach the tubule. Usually, the proximal tubule will get some very minimal proteinuria. That minimal proteinuria would be absorbed back by the vesicular system into the proximal tubular cells, and there it would either be degraded or it would be transported back into the blood at the tubular capillaries. Whenever there is an overwhelming proteinuria, then only the proteinuria will appear into the urine. The high sugars of diabetes mellitus will initially lead to a functional changes. There would be a osmotic diuresis into the ultrafiltration area, and later on there would be subtle, small structural changes, which would initially be completely reversible if the sugars are completely controlled. but later on, these structural changes can become permanent damage. In this, there is a orchestration of various metabolic pathways. The first and foremost and the most important is the RAS system. That is the renin angiotensin aldosterone system. The second would be the reactive oxygen species, oxidative phosphorylation, and the TGF beta pathway. These all lead to roundabout damage to the cells, to the structure, to the basement membrane, and to the porosity, which accentuates the proteinuria which is present in diabetic kidney disease. An important factor in this is also the nitric oxide system, which usually causes relaxation of the glomerular hypertension, and this, whenever it is attenuated, leads to glomerular hypertension. This is the important factor in causing proteinuria to get aggravated. Diabetic kidney disease would progress steadily. And even if the diabetes is completely controlled, still the initial effect of diabetes will continue to damage more and more. And usually it goes into a chronicity. There will be a slow, gradual fall in the GFR and an increase in the albuminuria. So that leads to staging of diabetic kidney disease. So the most primary effect of diabetes mellitus on the kidneys would be the GFR and albuminuria. The GFR initially actually rises because whenever there is an uncontrolled diabetes, that will lead to osmotic diuresis and a hyperfunctioning of the glomerulus because the ultrafiltration increases. So the normal GFR, which is expected to be 90, that can slowly rise to around 120 to even 180. And this goes into the hyperfiltration phase. This includes the renal reserve capacity of the kidney, and then slowly that gets used up and cells start getting damaged because of the metabolic effects of diabetes, and then slowly the cells go down, the glomeruli go down in function and in number and in structural damage, and the GFR starts falling. The GFR returns to 90 and then it goes into hypofiltration, less filtration, below 60. This is something which is going to be later on progressive. At the same time, the albuminuria, which is going to rise, starts rising later on. After the hyperfiltration has started, then the albuminuria increases and it initially rises to a higher level, maybe around 4 grams per day, 6 grams per day. But later on, as the number of functioning glomeruli go down, actually the proteinuria, albuminuria reduces and the proteinuria goes down. So it will be a curve which goes up and down both for the GFR and the albuminuria. The fall of GFR is earlier than the fall of albuminuria. Diabetic kidney disease or CKD of any other cause has been classified into the CKD stages 1 to 5. So that is irrespective of the presence or absence of diabetes mellitus high sugars. CKD stage 1 is when the GFR is more than 90, actually higher. This comes when there is a uncontrolled diabetes mellitus, or if there is a presence of a stone or high protein diet, means there is a structural damage, but functionally the kidney may be in the normal limits as per GFR. The CKD stage 2 will be GFR more than 60. There is sometimes a structural damage, there may not be a structural damage. Then CKD stage 3A, there will be the GFR more than 45. CKD stage 3B, the GFR more than 30. CKD stage 4, GFR more than 15. And later on, CKD stage 5, that is end-stage kidney disease, where the GFR is less than 50. In end-stage kidney disease, usually the patient will go on to dialysis, renal replacement therapy, and transplant. The other important aspect of diabetic kidney disease is albuminuria. It has been classified into A1, A2, and A3. A1 is albuminuria less than 30 milligram per gram of creatinine. A2 is albuminuria between 30 to 300 milligram per gram of creatinine. And A3 is albuminuria more than 300 milligram per gram of creatinine. Diabetic kidney disease structurally, microscopically, histopathologically is divided into various stages. Initially, there would be possibly no structural damage, light microscopy, immunofluorescence, and even in the electron microscopy. Later on, there would be subtle mesangial expansion and mesangial deposition, and later on, there would be structural damages in the various cells, including the mesangial cells, the endothelial cells, the glomerular basement membrane, and the peripheral podocytes. We may see Kimmelsted-Vinson nodules, that is nodular glomerulosclerosis, arteriolar hyalinosis, and interstitial fibrosis, tubular atrophy. That would be in the advanced stages. This all will lead to a functional damage also. Why are we afraid of diabetic kidney disease? Whenever there is a normal aging above the age of 40, there would be an annual decrease in the GFR function of the kidney by around 1 ml per minute per 1.73 meters square surface area of the body. Whenever there is a diabetes mellitus which is uncontrolled, the fall in GFR, the rate of decline in the GFR may worsen to around 2 ml to around 12 ml per minute per 1.73 square meters. So this leads to a rapid decline in the kidney function, and the person may go on to renal replacement therapy dialysis within few years. The only thing which can slow down the fall is treatment and supportive measures. Treatment management of diabetic kidney disease. First and foremost, treat the diabetes. Control it as much as possible without causing hypoglycemic episodes. Add up top up insulin if required if it is a very uncontrolled brittle diabetes in which OHAs, oral hypoglycemic agents, may cause hypoglycemic episodes. Usually, lifestyle changes are recommended, like for hypertension and diabetes, reduction in the sugar intake, reduction in starchy foods, exercise, stoppage of smoking, stoppage of alcohol, and leading an overall healthy lifestyle. In diet, protein intake is restricted if the person has already entered the CKD stages. No need to stop any kind of food, and limited non-vegetarian food is also allowed. In patients who are known diabetic, it is usually recommended to block the renin-angiotensin aldosterone system by adding a small dose of ACE inhibitor or ARB and later on aldosterone antagonists like finregaron. The hyperkalemia which may occur is to be managed, and a very small reversible rise in creatinine is tolerated by the physicians and informed to the patient when the medicine is ongoing. Also, the recommendations for dapagliflozin are coming up nowadays in diabetic kidney disease, and it also helps the control of the sugar, but also it helps in reduction in the rate of fall of GFR. It also has a side effect of causing more urinary tract infections and genital infections, but they can be tolerated by the patient if possible. Other things of CKD like calcium, phosphorus, uric acid, potassium, parathyroid hormone, lipids, all this is managed as a holistic medicine, and various aspects of the disease are controlled. We usually have a team effort where a dietitian is involved, physiotherapist is involved, medical social worker is involved, and sometimes a cardiologist is involved, nephrologist is involved. The primary focus of the team is the patient themselves. And nowadays, with the internet coming up and smartphones with everybody, monitoring of the sugar has become very easy because the HGT reading can be formed into a chart form, and this can be exported to the diabetologist as soon as possible if any problem is seen. Later on, whenever the GFR falls below 15 ml per minute per 1.73 meters square, renal replacement therapy is advised. And before that, in CKD stage 4, when the GFR is between 30 to 15, we would ask the person to have a vascular access on the hand, the AV fistula on the hand, or to prepare mentally for future renal replacement therapy. CKD stage 5 below 15, whenever it touches almost 10 or 5 in Indian patients, we would usually start elective dialysis and not wait for the patient to go directly into an ICU in a very unhealthy condition, and dialysis would usually be lifelong. There are instances when there is an acute factor because of fever or some drug ingestion, etc., where the creatinine suddenly jumps up and can partially go down when the acute kidney injury resolves. But usually, a diabetic with CKD who goes on to dialysis is for lifelong dialysis. Later on, a kidney transplantation can be thought about if the patient is less than 60 years old. So finally, nephrologists all over the world are after the diabetologist to check for the preventive aspects of diabetic kidney disease and to check the urine protein, urine routine microscopy once a year for every diabetic patient, irrespective of the control of diabetes. Thank you.